Thank you very much for this interesting topic to present, and also for your enthusiasm in staying for the very end and the last session. Thank you very much. I'm going to touch on anesthesia in the immature brain, and I've had the pleasure over the last several years of being involved in discussions on an FDA committee looking at this topic, and we can discuss their conclusions at the end of the talk. So it's impossible really to talk about anesthesia without talking about surgery. So I'm going to start kind of upside down because there's more data for the population that we are often studying in relationship to surgical exposure, and then go backwards to anesthesia. So the commonest reason that an infant, of course, will receive anesthesia is a surgical exposure. How common is that? Well, in preterm infants, approximately 10 to 20% of infants less than 1250 grams will actually undergo a surgical procedure. These include things like PDA ligation, surgery for necrotizing enterocolitis, as we heard this morning. The commonest is inguinal hernia repair, or a surgical or central line placement for some infants. So what do we know about surgical exposures and outcomes? Is there any data to suggest that there could be some association which would point the finger to the factors associated with surgery? Well, yes, there is. This is a study from the Victorian cohort, not my standard cohort, but a very large regional study carried out by Lex Doyle that looked at infants less than 27 weeks who underwent any surgery, and you can see the list there, compared with age-matched controls. And this documented a clear increase in cerebral palsy, sensory, neural, and cognitive disability. In a second study, increased challenges were noted in educational achievement following major neonatal surgery. This was 30 term-born infants. But clearly the type of surgery actually and the influence of other major potential confounding risk factors may be driving some of these outcomes. So let's look at what I said was the commonest surgical procedure that these infants undergo, that of inguinal hernia repair. There's very little data, actually, isolated data on the neurodevelopmental outcomes related to inguinal hernia repair. But this is an important concern because two very large trials are currently underway that you're going to hear a lot about in the next 2 years. One is called the GAS study and one is called the Panda study. And these are randomized controlled trials looking at the impact of anesthesia on infants after they have undergone inguinal hernia repair. The GAS study is taking 600 infants from multiple sites around the world, and it is randomizing those infants to either receiving servoflurane, that should say, with regional anesthesia, or regional anesthesia on its own. So in other words, an inhalational agent plus regional anesthesia, or regional anesthesia on its own, and then they're looking at cognitive testing at 2 and 5 years. They are about 400 infants in of their 600, and as you can see, they say, unless the Data Safety Monitoring Committee interrupts this study at 2 years, they want to complete the 5-year evaluations. So it means it's probably going to take 6 or 7 years before the full study is finished. There's a lot of discussion about this study as to whether there will be enough exposure, as you'll see by the time we get to the end of the talk, to actually truly answer the question of whether the inhalational anesthesia produces an adverse effect. The second study, the Panda study, will finish slightly earlier because they are really observationally looking at a single anesthetic exposure for inguinal hernia repair in 700 sibling pairs that have otherwise low anesthetic medical risks. They are in ASA group 1 or 2, and they're looking at longer-term neuropsychological outcomes because the concern in the GAS study is that the children might be too young to see differences in memory and attention and problems like that might be occurring with anesthetic exposure. So these two studies will give complementary information. So we undertook a study looking at the cohort we had in Victoria to try and address this question of surgical exposure. And we had 219 premature infants, and 20% of them underwent at least one surgical procedure. And as you can see, of those 51 surgical procedures, About half of them were inguinal hernia repairs, and the rest are sort of scattered, as you can see, through the other types of procedures. But this is, I think, very common in most neonatal intensive care units for this sort of array of procedures to be undertaken in very small infants. 7 infants underwent 2 procedures, 4 infants 3 procedures, and 5 infants underwent 4 procedures. There were 2 neurosurgical infants for reservoir placement, and there were also post-MRI infants who were excluded for various reasons. So that left 30 infants remaining in the study, comparing the surgical outcomes to the infants who did not receive a surgical exposure. So this is a pretty busy table, but what this table shows you is the infants broken down into their surgical groups. Inguinal hernia, bowel surgery, either for spontaneous intestinal perforation or necrotizing enterocolitis, and PDA ligation, by kind of the common factors that we know in our intensive care unit. And what you can note in particular is the inguinal hernia babies tend to be more likely to be growth restricted at the time they are born. Obviously, they're more likely to be male. And the postnatal steroid use was actually slightly higher in this group. The PDA ligations were more likely to be smaller infants, be on the ventilator for a longer period of time, and have a longer hospital stay. It's already been discussed about white matter injury today and its association with necrotizing enterocolitis, and indeed we find a strong association with surgical exposure, but it is all due to these children with necrotizing enterocolitis, and indeed 5 out of the 8 children who had surgical necrotizing enterocolitis had white matter injury. It's very, very common, and for any infant that you suspect of medical or surgical necrotizing enterocolitis, the white matter should definitely be fully evaluated. We went on then to do brain volumes, which we do by segmentation, as you can see here, looking at the grey matter, white matter, deep nuclear grey matter, and the myelin here in green. And what did we find? And these are in column A unadjusted and in B adjusted for all potential confounders in our 3 groups. And as you can imagine, the bowel surgery children with their significant white matter injury had lower tissue volumes and lower white matter volumes. But the striking thing for us was across all surgical groups, even after controlling for potential confounders, there was this selective reduction in deep nuclear grey matter volume. And we found this very concerning. At 2 years of age, we did not see a very significant impact on neurodevelopment, except unadjusted, we saw a significant impact in the infants that had inguinal hernia repairs, not what we expected to find. We thought it might be more down here or here, but it was these infants with inguinal hernia repair who had the highest risk unadjusted, which after you adjusted for all the confounders, including IUGR and male gender, as I told you, which were common, are no longer persisted as significant. We've just completed 7-year follow-up in these children, and we'll be looking at that data very shortly. So from here you can see surgery, as has already been reviewed, as common in the premature infant, and what I'd like you to note in particular is that nearly 10% of these infants are having 2 or more procedures. Infants who do undergo surgery are more likely to be growth restricted and experience greater neonatal respiratory morbidities. Preterm infants with surgical neck have a higher incidence of significant white matter injury, and all surgical infants have reduction in the cerebral volumes, but mainly in this deep nuclear grey matter volume here at term equivalent. So what does this really mean? Well, it could be that we are seeing some impact on cognition, but that's not entirely clear. And what I would say as a clinician is that a surgical exposure should be a flag for you for an infant at higher risk. But what does it mean? Is it really the surgery, or could it be that the anesthetic exposure is that's having the negative influence? And as I say, we are going to go on and evaluate at 7 years of age. There are multiple potential mechanisms. Is it the underlying condition, such as a PDA and altered cerebral blood flow? Is it the inflammation that's occurring, such as in neck, as we heard today? Is it the anesthesia and the analgesia around the surgery, the stress of the surgery, alterations in nutrition associated with surgical exposure? But what I really want to focus on, because it's of great relevance, is anesthesia and analgesia. So why are infants vulnerable to anesthesia? Well, developing neurons are actually programmed, as you've heard during these few days, to undergo this apoptosis, this sort of programmed suicide, if they are unsuccessful in meeting important developmental milestones. And those milestones rely on a neuron being excited by another neuron to maintain its survival. So the immature brain is this unique environment of sort of, if you like, standing, waiting to be told, am I going to stay or am I going to go? And that doesn't happen at any other stage in life. The original observations, which as you can note, were only first published in 1999, so the data you're seeing today is really only a decade old. These animal studies were actually serendipitous. The researchers were investigating an MDA-mediated brain injury when they accidentally stumbled across the fact that if you gave a particular type of antagonist, an NMDA glutamate antagonist, you had widespread neuronal suicide in the developing mouse brain. They then went on to try agents that they knew were used clinically that were standard NMDA glutamate antagonists. And these include servoflurane, isoflurane, ketamine, midazolam, propofol, and chloral hydrate. Some of these are going to be familiar to you all. And all of these, even at sub-anesthetic doses, triggered neuronal suicide in the developing brain. And within the rat, they went on to show neurobehavioral correlates. There was particular vulnerability noted in the deep nuclear grey matter in the striatum, which to me was of significance given the data that I've just shown you in our premature infants' brain volumes. So what does this look like in the animal model? So here is a typical rat brain that did not undergo, just received the standard control substance. And this is the cortex on the outer layer, and they have a very big striatum, these two big deep nuclear areas here. This is the hippocampus. This is an animal that has undergone isoflurane exposure, and what you can see here is everything that is dark black is undergoing suicide. So this is a caspase marker, that particular enzyme that you were told is activated for apoptosis. And the deeper layers of the cortex, there is dramatic apoptosis widespread. And within these deep areas within the striatum or the deep nuclear grey matter, you can see widespread neuronal apoptosis. So this is not subtle, right? I mean, this isn't like you have to really look hard to see that there's a lot of striking cell loss. This apoptosis was then gone on to be tested in primates, because people said, well, maybe, you know, it's just the mouse or the rodent. So they've gone on now in primates, and as you can see, just published 2 years ago, increased neuronal apoptosis after 5 hours of between 0.7 and 1.5 inhaled isoflurane in 6-day-old rhesus monkeys. That's close to 1 MAC for humans, which is about 1.6 to 1.8% inhalational. Most of our babies are getting between 1 and 2% inhalational. So let's go on to see what is known about the human immature brain. Well, there's a lot of areas of uncertainty, obviously, in translating this animal material to humans. What's the exact period of vulnerability? How long and when is the baby most vulnerable? What dose is required? Many of the animal studies have been criticised because they've used very high doses of intravenous anaesthetics, and most studies have exposed the animals to quite long periods of anaesthesia. If you give a mouse an hour of anaesthesia, that's about the equivalent to anaesthetising a human for 3 or 4 days. So there's a big difference in, you know, how you compare these two time periods. The clinical outcome that we should be looking for in humans, what kinds of impact should we be assessing? The role of anaesthesia among the other factors which contribute to injury. So what about the surgical stress and the inflammation and these other things? Could they be the things that are contributing? So here are some of the human studies, and I'm going to take you through a few critical studies that have just been published over the last 3 years. The first was there are 2 major Mayo Clinic cohorts, and a large amount of this work comes out of the Mayo Clinic. The first was published in 2019, where they looked at 230 children who had had surgery out of a large cohort before the age of 4 years. They documented an increased risk of learning disability that was associated with the number of anesthetics the child had received before the age of 4. They did not see any association with just one exposure, and that's an important message that you'll see repeated through these clinical studies, observational studies. The association between disability and multiple exposures persisted even after adjustment for chronic illness. The second study out of New York took Medicaid records comparing 457 children who had had an inguinal hernia repair before the age of 3, matched with those who had had no surgery. And after adjusting for several potential confounding factors, the children who had had an inguinal hernia repair had twice the risk of a diagnosis of a behavioural or developmental disorder. The Mayo Clinic cohort also went on to say, well, if it's bad as an infant, then maybe it's bad during delivery. So they went on to look at caesarean section deliveries under general anesthesia, caesarean by regional, and those born by vaginal, and they did not find an effect of general anesthesia. In fact, they found a somewhat confusing benefit of regional anesthesia, and they went on then to do a second study comparing those born by vaginal with and without regional anesthesia, and they didn't find a difference. So we think it's probably spurious, but this is very reassuring that mothers having general anesthesia exposure for caesarean section did not appear to render any increased risk to their infant. There is a Dutch twin study that looked at 1,143 monozygotic twin pairs. It's actually heavily criticised and was not strongly regarded in the FDA review because all of the information is collected by parent report. But what they found was that in twin pairs where one twin was exposed to anesthesia and the other was not, there was no difference in school performance. Randall Flick, who has carried out now the second cohort study in the Mayo with 5,357 children, 350 underwent procedures before the age of 2, and most of the data now is converging on the first 18 months of life being the period of greatest concern. There were 286 of these infants that had 1, and 64 had more than 1 exposure, and the median length was 75 minutes, actually, as you can see. The most frequent anaesthetic was actually a combination of halothane and nitrous oxide. So what they found was that for learning disabilities at 19 years of age, so we feel pretty comfortable that those children have declared themselves, that unexposed 21%, single exposure 23%, multiple exposures 37%. In particular, one disorder stood out, and that was of attention deficit hyperactivity disorder, 7% unexposed, 10% single exposure, 18% with multiple exposures. And after adjustment for multiple risk factors, the risk for ADHD with multiple exposures was about double. The final study I'm going to show you was just reported in Anesthesiology. They looked in Iowa at 577 infants. 58 of them had procedures which did not involve any, they said, potential confounding central nervous system problems. So they were inguinal hernia repairs, orchoplexy, pyloromyotomy, or circumcision. And as you can see, there's a little bit of a male predominance in those types of disorders. But they did not find a difference in the standardized test scores at school age in the two groups. But what they did show, and I think you're probably getting a sense for now as a repeated message, was an association between test score and the duration of the anesthetic exposure, with a greater than expected number of children having very low test scores. And this is the graph from that paper. So this is the duration of anesthesia with the fall in expected performance. So the longer the exposure, the greater the decline in performance. So we have to think there is quite a lot of concerning data. There's consistent data from rodents, primates, and now epidemiological studies that suggest that cognitive performance and potentially attention issues which have been linked with particularly the deep nuclear grey matter appear to be popping their heads out as being associated with at least the length or with multiple exposures to anesthesia in the first 2 years of life. The other thing I want you to be aware of is that there is increasing data that you can modify this neuroapoptosis, and you can modify it in several ways. You can accelerate it. So John Onley's lab, which was the first to report in 1999, the observation of the association between neuroapoptosis and NMDA antagonists, has now reported that you can accelerate this neuroapoptosis by co-administration of caffeine. And of course, this has ramifications for us in our practice with preterm infants, but also it's fairly standard for anaesthetists to give infants in the first 6 months of life some additional caffeine to avoid any post-operative apnea and bradycardia, and potentially to get the infant home more rapidly without concerns. So this is a concerning practice that we will see accumulating data over the next year. They have also noted there's some agents that mitigate the effect of anesthesia-induced apoptosis. Lithium, which I'm not sure will become readily available for us, but xenon, as we've talked about already, is becoming available as a neuroprotectant in term hypoxic ischemic encephalopathy, and potentially could be added into the circuit of the anesthetic gas exposure at the time of the anesthesia, or actually it's a pretty potent anesthetic gas on its own. The other is dexmedetomidine, so-called trade name of Precedex, which is increasingly being used in neonatal and infant sedation and anxiolytic properties, and that has been shown to negate the impact of these neuroapoptotic effects. Finally, what's not here is, again, a series of recent experiments from John Onley's lab that also show that dropping the rodent's body temperature by 3 degrees at the time the anesthetic agent is given negates the neuroapoptosis. So I always feel bad because I go to the operating room to try and keep my babies warm, but I might be actually doing the wrong thing, and I might be better to stay in the nursery and let them go up there and get a little bit chilly. So finally, what about use of these drugs outside of the operating room? What about what we do in the NICU? Well, one drug we have been studying is fentanyl. We studied 121 infants, and in our neonatal intensive care unit at this particular time, fentanyl was the sedative agent of choice, and our nurses liked it a lot. So about 3/4 of these babies received fentanyl during their hospitalisation, and 1/4 of them received more than 100 micrograms per kilo, more than 100 standard doses, mainly because they were on infusions. Those infants who received a high dose, i.e. the top quartile, were 6 times more likely to develop cerebellar hemorrhage, even after control for all the potential confounders that we could find. And the high fentanyl exposure group displayed greater impairment in head circumference growth from birth with a dose response. There was no relationship to change in body weight during NICU admission and fentanyl dose. So in other words, we saw a selective effect on head growth that was not present in body growth. And there's the change in Z-score from birth to scan in the high exposure group or the low exposure group with a p-value of 0.0009. We also looked at brain growth on our scans, and we found a relationship between fentanyl exposure and a decrease in the cerebellum or in the frontal lobes. These were the only 2 areas that were affected, the cerebellum and the frontal lobes. So as the dose of fentanyl went up, you declined from where you should be in your cerebellar growth and in your frontal diameter. And again, after multivariate adjustment, these remained significant. We have also studied morphine. This cohort in America were not exposed to very much morphine, but my original cohort in Australia were. As many of you will know, the NeoPain trial, which was a beautifully run trial, showed no difference in short or long-term outcomes. We looked at only 21 children out of our 227 in Melbourne that received morphine. The mean morphine dose, as you can see is there, was 1.2, with a range from about 1 to 5 milligrams per kilo. Exposure of these infants to low-dose infusions and boluses was not associated with any difference in brain volume at term or at 7 years of age. It was also not associated with any alteration on a vast number of tests of behaviour and cognition, either at 2 or at 7 years of age. So we sort of feel from this that low-dose infusions and boluses of morphines may not improve outcomes in the NICU, but there does not appear to be long-term detrimental effects. So unlike fentanyl, we did not see a negative impact from these low doses of morphine. So stress or pain with neonatal surgery is real, and what should you do when you're in this situation? Well, obviously, you've got to recognise stress or pain in some form. And then what I would hope was, apart from the feeling of the anaesthetic surrounding the surgical procedure, back in the NICU, that you can find safe methods of reduction of stress that will not interrupt or influence brain development. Non-pharmacological methods like supportive and bundling have been shown to reduce pain scores and improve the infant's comfort. Massage therapy or different types of parent touch or kangaroo care have also been shown to improve and reduce the amount of stress and the comfort scores. And there may well be safe drugs for pain therapy and anaesthetic agents, either alone or maybe we can give our conventional anaesthetics that we're using now in combination with a drug that may give a neuroprotective strategy, such as those that we have mentioned. So in conclusion, surgical exposure occurs in about 0.5% of term-born infants, but about 20% of preterm infants in the first 2 years of life. In the United States, that's over 250,000 infants each year. Is anesthesia exposure harmful in infants? I think it is very concerning at this stage. This is a unique period of brain development where they are vulnerable to both NMDA antagonists and GABA agonists. The animal data was very concerning and led, as you can see, to a rapid escalation over a decade in the number of human studies, which also confirmed a potential risk from either prolonged or multiple exposures. And there may well be risks from a single prolonged exposure, or the risks may still be present from a single exposure, but the noise may not be able to be easily detected. We do await the gas and the Panda study results to further guide us. The future define neuroprotective approaches that will block this apoptotic effect and may offer pain relief or anxiolytic properties such as xenon or dexmedetomidine. Reduce exposure to drugs that may upregulate these effects, such as caffeine, around the time your infants are receiving anaesthesia. Minimise exposure to heavy sedation and anxiolytics. Use very selective pain therapy pharmacologically. And appreciate other risks in your surgical infants, such as inflammation, whether there are modifiers for this, optimising nutrition, as we heard about this morning, and optimising rehabilitative therapies. The FDA, in its deliberations, came very close to considering a public warning about the effects of anaesthesia in the first 18 months of life. It decided against this for the concern that the public may not be able to appropriately weigh this sort of sparse data that exists at the moment, and that it may raise hysteria that would prevent surgical procedures that were necessary for small infants, for the infant's good. But the FDA is very close to trying to put out at least a preliminary warning that both anaesthesia and sedation exposures should be minimised in infants where alternatives could be sought. For instance, if the infants are undergoing procedures such as an MRI scan that could be done without sedation or anaesthesia. So if you can think when you are back in your practices about ways in which you can at least minimise these exposures and reserve the amount of time and the number of times that the infant may be exposed to these agents, then that would be the first step in helping minimise the potential adversity of these drugs. Thank you very much. Need to have